Now, any injury that results in trauma to the scalp, skull, or brain, okay, comes under head injury. Scalp is the outermost covering, skull is the bone, then brain is the organ which is present in our head. Traumatic brain injury and head injury are often used interchangeably these days. Yes, because this brain injury, if it is caused by trauma, okay, we call it head injury. But brain injury can occur by so many other medical way, like inflammation, infection, isn't it? All these can also result in a brain injury, but that is not called head injury. Head injury means it is caused by trauma. Now, a little bit about scalp. How many layers are present in the scalp? We have got 5 layers. And these, just like Abgar score, these, the letters themselves tells us what are the layers here.
Yes.
S stands for, yes, let me ask this. S stands for what?
Skin, sir, skin.
Skin, very good. C stands for?
Connective tissue.
Connective tissue. A stands for?
Epicranial, sir, it is epicranial aponeurosis.
Yes, this is aponeurosis. A for aponeurosis. Aponeurosis is a flat type of tendon. It's a flat sheet like tendon, also known as Gallia aponeurotica. A is aponeurosis. L stands for?
Loose areolar tissue.
Yes, loose areolar tissue. This is the 4th layer, loose areolar tissue, and there is a considerable amount of gap present there. Okay, so a blood clot can nicely collect in that gap area. And P stands for?
Pericranium.
Pericranium. Now, in one of the slide, I have written this full form later on, but right now I want to ask so that it will be quite clear. Most of the teacher love to ask you about this layers of the scalp. So please let me revise again. S is skin. This skin is very tough, okay, very thick type of skin, and it is very richly supplied by blood vessels. That's why any cut, any injury to the scalp, there is a brisk amount of bleeding, and it is difficult to control. We usually need to go for suturing. C, connective tissue. Okay, connective tissue, subcutaneous tissue, you can say. A for aponeurosis, L is loose areolar tissue, and P for pericranial. Now, scalp is a highly vascular structure, maybe the source of major blood loss in case of trauma, so we need to be careful. Sometimes patient may die because of continuous bleeding from the scalp, so we should be careful here. We need to stop that bleeding. Now, skull is a rigid and inflexible structure. Okay, because of this, there is a fixed volume inside, because it cannot be it is not a flexible structure. It is rigid. It's a bone, isn't it? It is composed of the cranial vault and base, and the organ which is present inside the skull is brain. It makes up 80% of the intracranial volume, and the brain is partially compartmentalized by the reflection of the dura, like the falx cerebri and tentorium cerebelli. These are the main parts of the reflection of dura. I want to add one more thing here, which is called falx cerebelli, falx cerebri, tentorium cerebelli, and falx cerebelli. Okay, these are the 3 main reflections of the dura, which are dividing our cranial cavity into a different compartment. Among them, the tentorium cerebelli is a very, very important one. So, because of this, we label it as a supratentorial compartment and infratentorial compartment. It is like a tent, and it is roughly present above the cerebellum and below the cerebrum, that area. Falx cerebri roughly divide our cerebral hemisphere into 2 lobes. It is present right in the middle. Okay, 2 cerebral hemispheres are separated by falx cerebri. A little bit about CSF. Okay, this is just the relevant one. We cannot completely cover everything here. CSF is constantly forming fluid, and it is formed by choroid plexus inside the ventricles of the brain. The most important ventricles are the lateral ventricle, which form CSF. It is formed at the rate of 500 ml per day. Okay, this is the rate of synthesis, and 150 cc or ml of the CSF is circulating at a given moment. Okay, now there is a clear discrepancy, isn't it? So you may be thinking, why is this? Because there is a rapid rate of absorption of the CSF. And from where CSF is absorbed? Yes, from where?
In the in the sagittal sinus, in the arachnoid granulation, and to the systemic circulation.
Exactly, is absolutely correct. CSF is absorbed through arachnoid villi and arachnoid granulation into the superior sagittal sinus. Okay, so that is the absorption site of CSF, and synthesis site is in the choroid plexus inside the ventricle. Most important are lateral ventricles, but also in third as well as fourth ventricle. The main functions of the CSF is it cushions the brain. This is a protective function. At the same time, nourishment is also the function of CSF. Now, a bit about cerebral blood flow. Brain receives 15% of the cardiac output at a given time, and brain responsible for around 20% of the total body oxygen consumption. So this is the one of the most important organ which consumes a lot of oxygen. And if somebody is hypoxic, if there is no oxygen supply to the brain, in 4 to 5 minutes, okay, there is death of the cerebral neurons. In many textbooks, it is written around 4 minutes or 4 to 5 minutes. So what is the lesson learned here? Very, very important point. Okay, please pay attention. If a person suffers from cardiac arrest means heart is not functioning. There is no pumping effect from the heart. There is still a bit of oxygen present in the blood. Okay, still a bit of oxygen present in the blood. So what is our main job? We do cardiac compression as hard and as fast as you can, so that that blood which still has a bit of oxygen will go towards the brain. That is my job if I want to save that patient. These days, the American Heart Association has completely revised. In the earlier days, we used to say ABC, airway, breathing, circulation. But these days, it has been changed. It is CAB now. C for compression. And this is the first thing we like to do. Forget about airway. That air which is present in the blood has to be pushed to the brain. Otherwise, brain will die within 4 to 5 minutes. What is the use of saving that person if the brain is dead? Okay, this is like a vegetative life. So, lesson learned. You are a medical student. You are going to be a doctor very soon. You will take a lot of trainings and things like that in this. There's no doubt. But remember one point: if somebody is having cardiac arrest, okay, don't think about anything else. Just start CPR. Just start chest compression as fast and as hard as you can, and transfer the patient rapidly to the hospital. There is a high chance of survival. Otherwise, the person will die. Now, let's move on. Let's talk about cerebral perfusion pressure, CPP. Now, this cerebral perfusion pressure is calculated by, this formula. If we subtract ICP from MAP, then CPP will be there. This MAP is mean arterial pressure, and ICP is intracranial pressure. So if I subtract intracranial pressure from mean arterial pressure, then cerebral perfusion pressure will be there. Now, this is the mean arterial pressure. This is how you calculate it. Every student know it already. Mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure. Okay, diastolic blood pressure plus 1/3 of the pulse pressure. Now, what is pulse pressure?
So it is the difference between the systolic and the diastolic blood pressure.
Exactly. Now I'll give you one job here. Okay, so all of you will do it very quickly right here in the class. Now calculate a mean arterial pressure of this patient who is having systolic blood pressure of 150 millimeter of mercury. Okay, of course, millimeter of mercury. 1 minute. And diastolic blood pressure of 90 millimeter of mercury. Now, can you do that? What is the mean arterial pressure of this person? Calculate and tell me. Yes.
Sir, 110, sir.
110. Okay. Yeah, we have got 110. Okay. So let's do it right here. So diastolic pressure here is 90. So here you put 90. And pulse pressure. What is pulse pressure here? 150 minus 90 is 60, isn't it? It is 60. Yes. So 1/3 of that 60 is 20. So 90 plus 20 is 110. Is absolutely correct. So this is the way you calculate MAP. And sometimes, you know, in the exam, this type of question will be asked to the student. These are important ones just to make sure whether you have this concept or not. Okay. So please be careful. And mean arterial pressure is the one which drives blood inside our arterial system. It drives blood. This is the, you know, driving force of the blood inside the arterial system. Now, intracranial pressure, okay, is the pressure which is present inside the cranial cavity, and if it is more than 20, okay, we should be careful. It should be treated. It should be decreased. More than 20 means high intracranial pressure. And maintaining, okay, cerebral perfusion pressure between 50 and 70 in non-operative brain injury is the fundamental treatment. Okay, so this is the goal in case of head injury or any other types of brain disease. Now, another type of important point here is Cushing's response, or Cushing's reflex, or Cushing's triad. Now, many students know this already. Cushing's response is seen in elevated ICP, and this is a combination of these three things together: hypertension, bradycardia, and tachypnea. This tachypnea actually is irregular type of breathing, also known as Cheyne-Stokes breathing. So hypertension, bradycardia, and irregular breathing or Cheyne-Stokes respiration is known as Cushing's reflex. And this demands decisive action because it already shows that there is a raised ICP. So we need to go for some treatment and we need to find out the cause. Regarding a bit of physiology here, there is a Monroe-Kelly hypothesis. And this hypothesis tells us the sum of the volume of the brain, blood, and CSF within the skull must remain constant. Therefore, an increase in one of the above must be offset by decreased volume of the other. Otherwise, there is very high intracranial pressure development. Okay. In other words, let me make it simple for you. There is no extra space there. We cannot increase these things. There is no space to accommodate them. Now, the important point, how to assess the patient. That's why what we like to discuss in today's class. Regarding the history, identify the mechanism and time of injury. What the patient was doing that time. Okay. Did the patient fall from a height? Did the patient suffer from road traffic accident or motor vehicle injury? Okay. Or did the patient suffer from bullet injury? Or the patient suffer from some stick injury? What was the mechanism? We need to ask. And what is the time? Definitely. Whether there was loss of consciousness, okay, at the time of injury and after that. Okay, very, very important question. Loss of consciousness, okay, means severity of the injury. Concurrent use of drugs or alcohol, another important history. Okay, this is important one. Who knows? they suffer from this accidental injury because of the effect of these drugs or alcohol. Medication that may affect the pupillary size, like glaucoma medication, opioid analgesics, any other types of medicines should be asked, because they may hamper for the neurological assessment. Pupillary size is one of the very important, clinical examination we do in case of head injury. You have to do it, many times in a day, whether those pupils are reactive or not. What is the size on either side? We have to measure, and then if there is any discrepancy in the size, means one pupil is bigger than other, that bigger size, site is having some problem. Ask about the past medical history, especially previous head trauma and stroke with the residual effect, and previous eye surgery, which can affect the pupillary size and response, like glaucoma surgery, for example. Okay, any iris surgery, those are the questions you should ask. Who knows, the larger pupil is simply because of that. And then ask about the presence of lucid interval. Now, what is lucid interval?
So lucid interval is so it is a short period of like regaining the consciousness after after some unconsciousness or because of head injury, sir.
Yes. Okay, I agree with you. Anybody else also want to say something here? Any other student?
Sir, it's a short period in which there is after a short period of unconsciousness again the patient becomes conscious, and then again, sir, after some time, sir, there is again onset of the original sign and symptom of that injury, sir.
Okay, yes, both of them are telling the same thing in a different way. Now, lucid interval means after the head trauma or injury, the patients will be shaken. The patient will be shaken up, or the patient had brief moment of unconsciousness, followed by regain in consciousness level, and after certain duration, after a few minutes or few hours, patient may become unconscious again. So this period of consciousness between the two periods of unconsciousness is known as lucid interval. Okay. I'm making it very, very easy for you so that you can remember it forever. The first time, patient may not be completely unconscious. Okay, it just be a brief moment of the lapse of concentration, or the person may fall on the ground and quickly regain the consciousness. Anything like that may happen for the first time, but there is a considerable gap, and later on, because this blood clot is slowly increasing inside the cranial cavity, and that is constantly increasing the pressure there. Once the particular pressure is reached, then the person will become unconscious again. This gap is called lucid interval. So in which pathology or which situation this lucid interval is present? Yes, which is that situation or condition?
Sir, epidural hemorrhage is very common with lucid interval, sir.
Exactly. Okay, so remember that is the answer. It's epidural or extradural hemorrhage where lucid interval is very commonly seen. We'll talk about that later also. Now, so these are the layers of the scalp, which the student have already nicely told: skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. Never forget this. Now, one small point I like to highlight: if blood collects in this loose areolar tissue, then they can come towards the forehead, and they can also reach in the eye. That's why in any case of head injury, especially the deeper type of scalp injury, there is development of the black eye, okay, or panda's eye, or raccoon eye. Different terms are given there. This is one of the important clinical manifestation of head injury, raccoon eye development, because of the connection of this loose areolar tissue, okay, anteriorly around the periorbital area. Now, concept of CPP is important in a hypertensive patient. Lowering the blood pressure too fast will also decrease the CPP, creating a new problem. This is cerebral perfusion pressure, and this is the pressure which is necessary for the perfusion of brain. So do not decrease the blood pressure too fast in a case of hypertension. You already know that. That's why gradual decrease in blood pressure is very, very important here. And another point, if the person with head injury is having hypotension, that hypotension is not caused by isolated head injury alone. We have to look for some other injuries in this setting, like intra-abdominal injury, okay, like any other fracture which has led to a lot of hemorrhage. Because usually in case of head injury, hypertension is more common than hypotension. But hypotension, if it is occurring, then some serious type of blood loss must have happened because of other associated injury. Now, this is about Glasgow scale. Okay, we have done this before. I'm sure about it. Okay, you already know it. It has got three components: E, okay, M, and V. E for eye opening, okay. V for M for motor response, V for verbal response. These are the different parts. Open spontaneously is 4. Open to verbal command 3. Open to pain is 2, and no response is 1. So this is the eye opening. Motor response, we have got 6 score maximum. See this? Obeys verbal command is 6. Localizes pain to the painful stimuli is 5. Now, if you apply some pain somewhere in the body and ask the patient, where do you feel the pain? If the patient localizes there, so there, it is 5. Flexion, okay, in case of some stimuli, means removing that particular part by flexing it, like one of the arm by flexing and removing, which is called flexion withdrawal, 4. Decorticate rigidity is 3. Decerebrate rigidity is 2, and no response is 1. Now, I think I've explained this point also with you in the last few classes. Decorticate and decerebrate rigidity means decorticate, the upper limbs are flexed, but the lower limbs are extended. Whereas decerebrate means all 4 limbs are in extension, and this is very, very serious condition. Okay. Now, best verbal response, we have got a maximum score of 5. You can clearly see it here. Oriented and converse. Converse means talk nicely, replying, 5. Disoriented and converses, 4. Inappropriate words, 3. Incomprehensible sound. It is just known as cooing, just producing some sound which cannot be understood, 2. And no response is 1. So the maximum score in Glasgow Coma scale is 15. And the minimum score is how much? What is the minimum score? Yes?
3.
Exactly. Exactly. The minimum score is 3. See this? 1, 1, and 1. You add all these three points together, it will be 3. It is not 0, okay? So many students just simply answer it is 0. It's not like that. It is 3. And maximum is 15. So this is how we interpret the Glasgow Coma scale. Severe head injury. If Glasgow Coma scale score is 8 or less, it is severe head injury. Usually the person is unconscious. Moderate head injury, GCS between 9 and 13, and mild head injury, GCS 14 or 15. In case of unconsciousness, Glasgow Coma scale is less than 8. Apart from that, one of the very easy clinical way of judgment of level of consciousness is known as ABPU scale. It's very commonly used in clinical practice. A, alert. V, okay, responding to verbal command or verbal stimuli. If I ask, hey, are you okay? The patient will respond. P, only responding to painful stimuli. No verbal stimulation is successful. And U for unresponsive. This is unconscious. So this is a very easy way. And if your consultant asks, according to Abpu scale, what is the condition of the patient? You answer it the same way. Doctor, the patient is in V, that means verbally responding. Okay, that is the way. Now, while we are assessing the patient, look for vital signs, and that those vital signs will tell you what is the Cushing's reflex, is it there or not. Remember, all the 3 points in Cushing's triad reflex are vital sign. One is blood pressure, another is pulse, and third is respiration. So look for them carefully, and if Cushing's triad is present, this means there is raised intracranial pressure. Search for signs of external trauma, such as laceration, hemotympanum, ecchymosis, and avulsion, as these may be clues to the underlying injury, such as depressed or open skull fracture. So examine head area quite well, examine for the ear, examine for the nearby area to look for laceration. Now, laceration is a severe type of injury. You all know that, you have studied this in forensic medicine. Okay, if a blunt type of weapon or instrument has led to the cut, we call that laceration. It should not be sharp weapon. Remember that sharp weapon leads to sharp cut type of injury. This is completely different. The weapon should be heavy, and the weapon should cause cut injury or severe damage there. Then this is called laceration. The edges of the lacerations are irregular. Okay, are irregular, and there is not much bleeding going on from the edge of laceration, because blood vessels are also crushed. Whereas in sharp cut or clean cut injury, there is excessive bleeding. Hemotympanum, what is the meaning? Anyone?
Sir, it is presence of blood in the middle ear, sir, around the, sir, it is the bleeding around the tensor tympani muscle, sir, in the middle ear.
Okay, so you can just say it is a presence of blood in the middle ear. Okay, that's completely fine. When we examine that here, we can see bulging of the tympanic membrane, or the color of the tympanic membrane may be red or a little bit bluish. It depends how long the blood is there. This is known as hemotympanum. Sometimes what happens, there is rupture of the tympanic membrane, so the blood will come out from the middle ear as well. Ecchymosis is a blue patch, and avulsion, okay, is avulsion of certain parts of our body. Okay, this is a result of severe injury. Now, depressed skull fracture and open skull fracture, and closed skull fracture, there are different types. Depressed means, a part of the skull is going inside, deeper inside, so it may damage the brain. So that is a big danger of depressed skull fracture. Open skull fracture means the covering, that is scalp, is severely lost or damaged, so that I can see the fracture site from outside, or the fracture site is communicated with external environment. This is known as open or compound skull fracture. There is a high chance of infection as a result of contamination here. And closed skin fracture means only there is break in the bone, but scalp is intact. This is known as closed skull fracture. So there are different terms, according to situation. Anisochoria means unequal pupil is found in a small percentage, around 10% of the normal people. However, anisochoria in the patient with head trauma is pathological until proven otherwise. A small example I can give you here. The right pupil is dilated and left pupil is normal size. That means something is going on towards the right side of the brain. So this type of information is provided by unequal pupil size. Let's move on. Now, this is a slide which is giving a little bit of important point regarding increased intracranial pressure. Okay, when you study neurology in the 7th semester, all these points will be highlighted in a lot of detail. Okay, but right now you need to know something. Change in level of consciousness. Level of consciousness means it is decrease, and if it is a very much decrease, we call that loss of consciousness or unconsciousness. papilledema, we already discussed that before, impaired eye movement, decreased sensory or motor function. All these may be feature of increased intracranial pressure as a result of damage to the brain. Headache, pupillary change, changes in the vital sign like increased blood pressure, decreased pulse, and change in respiratory pattern. This is known as Cushing stride. Vomiting, this is a projectile type of vomiting usually. Okay, these are important feature in adult, whereas in infant, less than 18-month-old, bulging fontanelles are very common feature. Cranial suture are widely separated. There is increased circumference of the head, okay, which is known as, what is the medical term for that? Increased head circumference?
Hydrocephalus, macrocephaly.
Macrocephaly.
Exactly, it is known as macrocephaly. Okay, macrocephaly, and the most common cause of macrocephaly is hydrocephalus. Yes, so that will be a better description. And high pitch cry, in any type of in the increased raise intracranial pressure, there is high pitch cry. One of the common causes meningitis as well. So Cushing stride, so many times we have talked till now, raise blood pressure, decrease pulse, and irregular type of respiration. Okay, irregular respiration. Now, what is the difference between shock and raise ICP? In shock, there is decreased blood pressure, increased pulse, and excessive fast type of breathing. So this is the difference between shock and raise ICP. So we need to be careful. Now, sometimes what happens? The same patient may be having severe head injury. The same patient may be having some other type of injury like intra-abdominal rupture of the organ, like spleen rupture, liver rupture, isn't it? Massive type of fracture, which is leading to a lot of hemorrhage. So shock, okay, is winning over the ICP. So hypotension may be seen, and this is a very serious case. Okay, very, very serious case. Now, what are the diagnostic study you like to do? The most important test here is CT scan. But before doing CT scan, you need to immobilize the head or neck, and you think there is a high chance of cervical spine injury in this case, so I need to immobilize the neck or head. Otherwise, the cervical spines are damaged, and there is high chance of damage to the cervical part of the spinal cord, and that person may develop quadriplegia or quadriparesis. All 4 limbs may be paralyzed. Along with that, even diaphragm may be paralyzed. So this is a very, very important point for us. So let me clarify this again. Any patient with head injury, okay, we always presume this patient is also having cervical spine injury until proven otherwise. So put a collar, okay, collar around the neck. Preferably hard type of collar is preferable, so that there will be no movement of the neck. A CT scan will be taken, and these are the indications for head or brain CT. Any cases of neurological deficit, we go for head CT scan. Neurological deficit means some neurological damage like hemiplegia, okay, like monoplegia, like loss of the vision, loss of hearing, any cranial nerve deficit like that. If there is persisting depression or worsening of the mental status, then CT will be done. Prolonged coma or loss of consciousness itself. Depressed skull fracture or linear fracture overlying a dural venous sinus or meningeal artery groove, as demonstrated with skull X-ray, just to make sure whether internal hemorrhage has occurred because of this or not. So CT scan will tell you how much blood is collected inside. Now see this. So this is the clinical type of topic. So time and again we'll talk a little bit clinical type of discussion. And enlarging pupil with a concurrent decrease in level of consciousness is strongly suggestive of uncal herniation. Now, what is uncal herniation? Anybody? What is that?
Sorry, sir.
What is this? Uncal herniation means which area is herniated? Where? Where exactly in the brain? This is temporal lobe. Uncus is a part of temporal lobe of the brain. When this uncus is herniated from the tentorial hiatus, so let me write it here. It is tentorial, okay, hiatus. It's tentorial opening. Tentorium cerebelli is right there. Remember that. So from the tentorial cerebelli, the brain stem is passing downwards. So we are talking about that area. So if there is a herniation of the uncal part of the temporal lobe, it will give compression to the third cranial nerve or oculomotor nerve, and as a result of that, oculomotor nerve will be dysfunctional. So there will be enlargement of the pupillary size. Very important point. At the same time, brain stem is compressed. There is reticular activating system at the central part of the brain stem, and when that is compressed, there will be decreased level of consciousness. So these are important two features of uncal herniation. And uncal herniation can occur in case of raised ICP. Now, these are the initial approach in a case of head injury. So this is important knowledge. So let me quickly go through it. All head injuries are a C-spine injury until proven otherwise. Already talked about. Though C-spine injury may occur in 5% of the case, but this is such an important, a coexisting injury that a person can convert into quadriplegic patient if we do not take care of. Ensure the secure airway. Hypoxia is an independent risk factor for mortality. So all head injury patients should be given a good flow of oxygen through non-rebreathing mask. This is known as non-rebreathing mask. High flow, 100% oxygen can be given at the rate of 10 to 15 liters per minute. Patient with Glasgow Coma scale less than 8 or other indications should be intubated via the orotracheal intubation. This is unconscious patient. See this. GCS less than 8 is unconscious or comatose patient. So to protect the airway, they should be intubated. Preferably cuffed type of endotracheal tube is used so that there is no chance of aspiration. All patients should be monitored with pulse oximetry and frequent check of respiratory status. Patients who are intubated should get an arterial blood gas analysis just to make sure they are not hypoxic. Maintain mean arterial pressure more than 90 with fluids. Don't allow it to drop, okay, less than 90. If it is less than 90, then cerebral perfusion pressure cannot be maintained. Hypotension is an independent risk factor for morbidity and mortality. And one other thing, avoid glucose containing fluid. I think I have explained this point before, but let me ask this question to you. Why glucose containing fluids are, not used in case of head injury?
Yes, sir. Sir, basically, sir, like the glucose containing fluid, let's say they are absorbed intracellularly. So that's why we avoid the glucose containing fluids, sir.
Okay. Yes. I want to hear some more answer also. Anybody else? Anybody?
Sir, because glucose is the osmotic diuretic, so also lead to the more hypertension. Sir.
Yes, sir. Yes.
Yes. Now see that, yes, you are right. You are right. Okay. So let's combine both of those answers together. When we give glucose containing fluid, glucose will not stay in the intravascular compartment, okay, for a longer time. Glucose will definitely diffuse outside. Okay. So, and it will enter into the cells. Now what will
So
happen?
glucose will cross the blood-brain barrier. It will push blood.
Okay. Yes. Fine. So listen here. So what is happening is glucose is going out of the blood vessel into the tissues, isn't it? And glucose is an osmotically active compound, definitely an osmotically active compound. Okay. So there is difference in osmolality now. Whenever osmolality is acutely changing in that setting, then there will be movement of the fluid. That movement of the fluid can result in cerebral edema. Cerebral edema. So to avoid that, we avoid the glucose containing fluid at this time. This is the explanation. At the same time, you should watch carefully for Cushing's response. All these things are important. Now, the most important points I have already taught to you. This is what I like to teach mainly. Now, some additional things are types of skull fracture. Now, linear, which is called non-depressed fracture, depressed fracture, compound fracture. Okay, these are the different types. And basilar fracture of the skull if it is occurring towards the base of the skull. Linear fractures are not dangerous at all if they are closed one, because skull is a flat bone and you don't need to do anything on the flat bone. The fracture will heal on its own. Okay, just rest is enough. Whereas if it is a depressed one, it carries a much greater risk of underlying brain injury and complication like meningitis and post-traumatic seizure. So as soon as possible, it should be treated. Means we should pull back that depressed fragment upwards. Okay, that is the treatment. Regarding the basilar, signs including periorbital ecchymosis, which is known as Raccoon Eye, retroauricular ecchymosis, which is known as battle sign, Otorrhea, Rhinorrhea, hemotympanum, and cranial nerve palsies. Now, these are quite important term and very, very commonly asked in your MCQ exam also. And that is the main reason why I want to cover this topic for the students. The Raccoon Eye develops when anterior cranial fossa is damaged. Anterior cranial fossa. Okay, this is also known as panda's eye. The blood clot or blood will collect around the eye. Exactly looks like Raccoon's eye. Battle signs means the mastoid process is developing bluish discoloration or ecchymosis. This is battle sign. When middle cranial fossa is damaged, then battle sign will occur. Otorrhea is also feature of middle cranial fossa injury. Rhinorrhea is a feature of anterior cranial fossa injury, and this is usually caused by CSF rhinorrhea and CSF otorrhea. Now, cerebrospinal fluid is coming out in the serious type of injury. Hemotympanum, just now talked about, collection of blood in the middle ear, and cranial nerve palsies also can occur. This is damage to the cranial nerve. So this is a depressed fracture of the skull, and it's a compound fracture. Compound means the superficial layers of the scalp are severely damaged so that I can see the fracture site. This is known as compound or open fracture. So here, depression fracture, compound fracture. Okay, this is called hairline fracture, and this is subdural hematoma along with the fracture. Now, this is known as Raccoon Eye. Raccoon Eye. So this is a raccoon. So exactly that eye would occur in the patient. So this is a very, very important feature of anterior cranial fossa fracture, or sometimes it can also occur because of severe type of head injury where there may not be any deeper type of bleeding, but if some layers of the scalp is having bleeding, then also this type of feature can be seen. This is known as battle sign. So let's again ask you, what is battle sign? Just look at the picture and tell me what is battle sign.
Mastoid process bleeding, sir.
Exactly. This is called mastoid process or mastoid bone. See this is pinna, and this a bit of prominent type of bone is called mastoid process or mastoid bone. This is a ecchymosis of the mastoid bone. This is known as battle sign. And many of the textbook, it is written, this is a feature of middle cranial fossa bleeding. Hemotympanum. See this. Now, this is a tympanic membrane. This is an otoscopic view. Otoscope is a special instrument which is used to examine the middle ear of the tympanic membrane. There is a tympanic membrane. Okay. So this is a better than this, this one. See here, there's a definite blood clot which is collected. Hemotympanum. Sometimes this tympanic membrane is ruptured and this blood may come outside as well. Now, sometimes there may be diffuse type of intracranial lesion. One of that is called cerebral concussion. Now, concussion means shaking of the brain, shaking. So there is transient loss of consciousness in concussion, which immediately occurs after blunt type of injury, non-penetrating head injury, and this is caused by the impairment of reticular activating system, which is making the person alert and awake. And when this reticular activating system is damaged, then the person will lose the consciousness. This is only for a short moment or duration. This is known as concussion. Recovery is often complete. However, residual effects such as headache may last for some time. So shaking of the brain is known as cerebral concussion. Just remember like that. Another is a bit severe type of injury, that is known as diffuse axonal injury. So this is caused by microscopic shearing of the nerve fiber. So by gross observation, nothing can be seen, but something is happening inside the nerve fiber. And one of the very important point is, if we do the CT scan, no mass lesion or no important abnormality is seen there, but still a patient may be in coma. So this is known as diffuse axonal injury inside the brain. So this person has to be admitted in intensive care unit under the neurosurgical care, and mortality is approximately 33% here. So this is a serious type of injury. So axonal brain injury means, remember, there is no blood clot present inside the brain. CT scan is usually showing no change, but still patient is unconscious, and because of severe type injury. Same thing is written here. Okay, you can go through this. Now, focal intracranial lesions, it may be contusion or it may be intracerebral hemorrhage. Now, cerebral contusion means it occurs when the brain impacts the skull. Some blunt type of force has hit our head, blunt. So as a result of that, the brain will shake. Okay, so there are two types of injury occurs now. One, the place where there is a direct injury, we call that the site of impact. We call that coup type of injury. And on the exact opposite side of that site of impact, we have Contraco type of injury. So coup injury and the Contraco injury. This Contraco injury occurs because of the movement of the brain, which is hitting the back side of the skull, and there also the injury occurs. Patients may have focal deficit, mental status change, okay, and it may ranges from confusion to coma. Okay, so remember, this is an important term: coup injury and Contraco. Coup occurs at the site of impact, Contraco on the contralateral side. Intracerebral hemorrhage occurs because of tearing of the intracerebral blood vessels, and it is difficult to differentiate from a contusion. Now let's see some of the picture here. So this is coup and Contraco injury. So a coup injury occurs here because this is a fixed object, and this head is impacted on that fixed object. So exact at this site, okay, there is a direct impact unity. So this is a coup injury. As a result of this, the brain shakes and there is a movement of the brain. So on the back side, it hits the skull. So there is a Contraco injury occurs. Coup injury and Contraco injury. See this? Backside here. Here is the Contraco injury. Now, to diagnose the CSF rhinorrhea, we need to collect the sample, okay, which is coming out from the nose, and that is placed on a tissue paper, Okay, in case of CSF rhinorrhea, there is one clear transparent ring forms outside the blood clot, and that transparent ring is caused by CSF which is present there. This is the important type of test to diagnose CSF rhinorrhea. And CSF rhinorrhea occurs in case of anterior cranial fossa fracture, which may occur in any type of head injury. This is a typical scenario. Just let's go through it. A 20-year-old female has brief loss of consciousness following head injury. She presents to the emergency department awake but is amnesic for the event and keeps asking the same question again and again. So this is because of the concussion. The brain has shaken, and for a certain duration, she will show this type of symptom. Now, this is the ring test for CSF rhinorrhea. That's what we are talking about just now. If we collect that sample at the center, see this? This is a blood clot, and around that, there is a bigger type of ring present, which is a clear type of ring. And this is because of diffusion of CSF here. It exactly looks like this. This is by blood, and this, the outer one, is caused by CSF. This is also known as halo sign, a double ring sign, because these are the two rings which are present, double ring. This type of test can also be done in case of CSF autoria, not only for rhinorrhea. Okay, CSF autoria as well. The concept here is whether CSF is mixed with the blood or not. We want to detect that. So this is a bigger picture which is showing the same thing. CSF rhinorrhea, autoria, or hemotympanum. CSF autoria only occurs when there is rupture of the tympanic membrane. Then only it will come out. Otherwise, it will just collect inside. This is a basilar skull fracture, which is showing the battle sign. So this is battle sign. This is Raccoon Eyes. So in the exam, if these type of questions are asked to you and ask the option, you can easily choose the correct one. Battle sign usually occurs in middle cranial fossa fracture. Raccoon Eye in anterior cranial fossa fracture. Now there are different types of intracranial hematoma. There are epidural hematoma, subdural hematoma, and intracerebral hematoma. Even some more terms are there, like subarachnoid hemorrhage and even intraventricular hemorrhage. These all will be taught very nicely to you in case of neurology in internal medicine. Okay, so here is a depressed skull fracture, and it has lead to collection of the blood clot here. See this. Now this is a CT scan which is showing epidural hematoma. Now one important point I like to discuss with you here is, see this. This is an active type of bleeding. So which artery is ruptured here? Which artery? Which artery is this?
Middle meningeal artery, sir.
Yes. Yes, middle meningeal artery. Middle meningeal artery. And this is the active type of hemorrhage because this is the arterial bleeding. So it will lead to convex shape of this blood clot. This is a convex shape. Clear-cut convex shape, I can see. This is the hallmark of extradural hemorrhage or hematoma in the CT scan. And blood clot, which is active or acute type of blood clot, is always seen white in the CT. So this is the epidural hematoma. In detail, you already know from your pathology discussion. Okay, I still remember, I've nicely taught you there. This is the collection of blood between the dura and the skull, okay, in the epidural space. It is mainly occurred by the rupture of middle meningeal artery when temporal bone is fractured. It is typically biconvex or lenticular in shape. Lenticular means lens-like shape. Lens, and lens is a biconvex lens in us. There is a typical lucid interval present. Okay, also known as talk and die syndrome. Talk and die syndrome, because once the second episode of unconsciousness occurs, and if we cannot detect that in time, the person will die. It requires early neurosurgical involvement and hematoma evacuation if we want to save this patient. So quick diagnosis is very, very important. Now, see here. Another is subdural hematoma. Please mute yourself. Subdural hematoma. Now, what is the subdural hematoma? This occurs if the blood clot is collected in the subdural space, and this mainly occurs because of rupture of the bridging vein. Bridging vein. So this is a venous type of blood. So it collects, slowly. Okay, slowly. It is not as alarming as epidural hemorrhage, but it will also lead to massive collection of the blood clot if it is not treated in time. So it may be acute, subacute, or even chronic. And alcoholic and elderly people are most commonly having a subdural hematoma. Now, this is the subdural hematoma, and this swelling or the collection of the blood clot is between, the dura mater and arachnoid mater. Subdural. It is not mainly caused by the, severe type of head injury. Okay, it may be caused by slight amount of head injury and more common in alcoholic patient. Now, this slide is telling us between the differences of epidural and subdural hemorrhage. See this, it is shown in the red color, means it is the arterial bleeding. It is shown in blue color, it is a venous blood. This is middle meningeal artery blood, and this is rupture of any bridging or emissary vein. Okay, and both of these may result in raised ICP. There's no doubt. If your teacher asks you which is more serious, I'll always choose epidural or extradural hemorrhage is more serious, because we don't have enough time, to save this patient. We have a little bit more time to save a subdural hemorrhage because it is not very acute type of presentation. But nevertheless, both should be treated. So another schematic diagram which is showing the same thing, epidural hemorrhage and subdural hemorrhage. Even intracerebral hemorrhage is shown here. And this is known as midline shift. It is pushing the center part of the brain to other side, midline shift. This is the CT scan, which is showing, see here, here is the hemorrhage, here is also hemorrhage. This is a biconvex. So this looks like epidural and this looks like subdural. I cannot see any convex shape here, but this is clear-cut convex. So this is epidural and this is subdural. Okay, and this we have already talked before. So you can go through this on your own.